Good day, everybody. This is Chris with the Ancient Scholar. What I'd like to do today is I'd like to go over the current treatment recommendations for COVID-19. I'm recording this at the end of 2020, so this is December 31st, 2020, and this is going to be a review of the most current guidelines based on the most currently available information and evidence that we have access to. Okay, so let's go ahead and begin. So just to recap, approximately 80 to 90% of all patients who get COVID-19 will not require hospitalization. All right, I think it's very important for us to appreciate that, right? So most people who get sick with COVID-19 will not need to go to the hospital and will recover or have a reasonable recovery outside of the hospital, i.e. at home. So most patients will not develop serious signs and symptoms, particularly during the first week. During the first week, this is the early viral phase. Most people will not need to go to the hospital. Most people will not become hypoxemic. Most people will not develop respiratory failure. They will not develop pulmonary emboli, and they will not require aggressive ventilatory support during the first week. They may feel bad. They may have a fever. They may present with a generalized respiratory viral syndrome, but they will often not require hospitalization. However, following the first week is where that 10 to 20% of the population that gets COVID will typically develop problems. So it is very important that when we are monitoring patients that have been diagnosed with COVID, it's very important to know when their signs and symptoms began, when they were actually diagnosed with COVID via reverse transcriptase PCR, RT-PCR, for us to understand where they are at in the time course, the progression of their disease. As a note, the highest risk patients include patients that are over the age of 65, and in fact, approximately 40% of all the COVID cases in the United States have come from nursing homes, long-term care facilities. So it is an absolute travesty that we have failed to protect these most vulnerable people. And perhaps had we been more aggressive about protecting them in the beginning, prior to out-of-control community spread, we may have very well been able to impact substantially the total number of COVID-19 cases and possibly mortality. Other people that are at high risk for complications are people that have chronic medical conditions. Some notable examples: obesity and metabolic syndrome. Metabolic syndrome often goes along with obesity, and that is to say that people who develop insulin resistance, hypertension, and other problems associated with obesity, such as elevated lipids, blood lipids, are people that fall into the category of metabolic syndrome. And typically, we're looking at BMIs exceeding 30. Diabetes is a big risk factor for multiple reasons. Obviously, metabolic syndrome being one reason. And we know that chronically elevated blood sugars are generally very unhealthy for many of the different cells and tissues within our bodies. People that have underlying respiratory issues, such as a chronic obstructive pulmonary disease or COPD, people that have underlying cardiovascular disease, kidney disease, and other diseases that can impact their immune system, such as organ transplant patients, or patients who are chronically immunosuppressed, such as patients with various autoimmune disorders that are receiving immune modulating therapies such as rheumatoid arthritis and systemic lupus erythematosus, or SLE. Okay, moving on. So let's talk about keeping high-risk patients out of the ICU. All right. So you have somebody who's been diagnosed with COVID-19, and initially we try to manage all people at home, and we've identified a person as being higher risk, at a higher risk for developing more serious complications. Maybe someone who's elderly or somebody who has multiple comorbidities, like we talked about a little earlier. So, what are some considerations here? Well, let's talk about this. In patients that are greater than 12 years old, weigh over 40 kilograms, that's approximately 88 pounds, they are not hospitalized, and they are not requiring oxygen therapy. Not hospitalized, not requiring oxygen therapy. All right. What we can do is we can consider a medication known as bamlanivimab, also referred to as Bam Bam or the Regeneron cocktail. This is a monoclonal antibody, so it is a very specific antibody, one antibody that is developed artificially in a lab to attach to a very specific site on antigen, I believe, and in this case it is a spike protein. This particular medication can be given in the first 10 days, and there is evidence that suggests that when given early, it will decrease the need for hospitalization. I believe there are some studies that suggest up to 75%. So with that in mind, the concept of giving convalescent plasma, that is, infusing plasma from a patient that has recovered from COVID-19 into a patient who is at higher risk for complications of COVID-19, is no longer routinely recommended. Really, the monoclonal antibody therapy seems to be the better way to go. It is certainly safer, and it does not have all of the various clotting factors and immune agents, white blood cells and whatnot, that can increase the risk for problems developing. Okay, moving right along. So let's say that the signs and symptoms exacerbate, or the patient's SpO2 or pulse oximetry readings go under 94% following the first week. So after the first week, if the patient continues to have substantial signs and symptoms or worsening signs and symptoms with a decrease in the SpO2, another medication that we can look at giving is a dexamethasone. This is a steroid. Now, I want to be very clear, steroids are not to be given during the first week. This is the viral phase. It may actually be dangerous to give steroids during the first week when you really need the immune system to ramp up and develop a good humoral and a good cell-mediated response. You don't want to interfere with that, but it is hypothesized that following the first week, it is an over exaggerated immune response, different cytokines like interleukin 6, for example, that then can mediate a toxic or a rather problematic over exaggerated immune response. And at that point in time, introducing medications that modulate the immune system would be indicated. So again, after the first week, and there is very compelling evidence. There is a very good trial that was done out of England some months ago, looking at large groups of patients that showed a very clear signal for patients benefiting from steroids, specifically dexamethasone, also known as Decadron here in the United States. And the typical therapy is going to be 6 milligrams a day, every day, for about 6 days. Some people will modify that, maybe as few as 5 days, maybe as many as 10 days, depending on the situation. But typically, we see 6 milligrams POQD. Typically, we want to give this orally if we can. If the patients can tolerate it orally, so we're not giving anything IV that we don't need to give. Now, alternatively, if you don't have dexamethasone for whatever reason, prednisone 40 milligrams is approximately equivalent to a 6 milligram dose of dexamethasone, and so that might be a reasonable substitution if need be. What about aspirin, acetylsalicylic acid? Aspirin every day? Well, there isn't clear evidence of benefit, but it is reasonable to perhaps think about having a patient take an aspirin a day with or without dexamethasone. Okay, so just to recap, not all COVID-19 patients require steroids. Do not give during the first week, during the early viral phase. Typically, this is the second week plus with severe signs and symptoms at home or in the hospital. So home patients and hospitalized patients alike can receive dexamethasone therapy. And indeed, many of the patients that I have taken care of in the COVID unit have received dexamethasone or are receiving dexamethasone. And that should come as no surprise that most of the patients that I take care of in the COVID unit are patients that are well into their disease course. That is to say that they have been COVID positive, or they've had signs and symptoms exceeding a week, and they are in the second week plus, and they've had some exacerbation of their condition. Okay, moving right along. Okay, let's talk about the early inflammatory phase. Typically, this is going to be following that first week, so you're looking at weeks 2 to 3 right in there. If this patient is admitted to the hospital, okay, what do we need to do? So we're talking about initial workup here. So the patient, we've tried to keep them at home. They have deteriorated. They've gotten worse. They are now in the hospital. They're going to need to be hospitalized. What's our workup going to look like? All right. So what are the labs that we want to look at doing? So we want to get a CBC on these patients. That is a complete blood count with a manual differential. That's going to be a very important part of taking care of that patient. CBC with a manual differential. All right. Specifically, what can happen is these patients can develop a lymphopenia and neutrophilia. So their lymphocytes can become low and their neutrophils can become elevated. And there is a ratio that we'll talk about here in a little bit that can help identify higher risk patients. In addition to that, we do want to get a complete metabolic panel, also known as an SMA12 or a KIM12. We're going to want to look at the, from that, we're going to want to get an idea of their renal function, their GFR, their glomerular filtration rate, their creatinine clearance rate, and typically you want that greater than 30. Less than 30 is concerning, and we may need to modify therapeutics based on a low or compromised renal function. In addition to that, we're going to want to look at the liver function tests, the AST, the ALT specifically, and do the LFT values of the patient exceed approximately 5 times what is considered normal for the lab that has drawn that patient. If they are, then that is a concerning, a more critical situation. In addition to that, we're going to want to draw ferritin levels, and we know that increased ferritin levels is a concerning finding in COVID patients. In addition to that, we're going to want to draw for procalcitonin levels, and we know that elevated procalcitonin levels can be concerning as well, and can help us predict patients that may not do as well. In addition to that, there is a ratio that I'll talk about here in a little bit of ferritin to procalcitonin, and that ratio can help us identify the presence of secondary bacterial infections. Now, I'll talk about this a bit more in therapeutics, but just as a reminder, we do not empirically treat COVID-19 patients with antibiotics, right? These patients may have signs and symptoms and even radiographic findings suggesting pneumonia, right? A viral pneumonia is not an uncommon thing. However, if we do not have strong evidence suggesting the presence of a bacterial infection, antibiotic therapy, antimicrobial therapy is generally contraindicated in these patients. Right? It's generally not something that is suggested, and we do not want to be throwing antibiotics at these patients. Right? We already, prior to COVID-19, have had problems with antimicrobial resistance to antibiotics, and we are only making that problem worse by throwing antibiotics at patients that don't need them. All right, because once we get through COVID-19, we're still going to have all of the other infectious disease stuff to worry about, and we are making things substantially worse by throwing antibiotics at patients. We're going to want to get coag profile, specifically a D-dimer, a PT, and a PTT, or an APTT. The PT and PTT are bleeding times. The higher these are, the more the less effectively a patient is able to make clots. The D-dimer, of course, is an indication of hypercoagulation. That is to say, somebody who is more likely to develop a clot. It tends to have an elevated D-dimer. C-reactive protein is generally recommended. That is a general inflammatory marker. A troponin is indicated because some patients with COVID will develop cardiovascular complications. They can even have things like STEMIs and NSTEMIs, and so we want to be able to rule that out. And so it is also reasonable to get a baseline 12-lead ECG on these patients. In addition to an arterial blood gas, looking at the PF ratio, that is a PaO2 divided by the FiO2. Generally, in a healthy patient, that ratio is going to be very large, say greater than, say, 300 or so, and in sick patients, it'll become very small. And it is also reasonable to get a chest x-ray on these patients. In general, more advanced radiological investigations like CT scan are generally not recommended. If you do suspect that the patient has developed a pulmonary embolism, of course, it is more than reasonable to get a spiral CT scan to rule out pulmonary embolism. Okay, what are some additional history and investigations that we want to look at in hospitalized patients? This is very important. The date of symptom onset and the date of first positive COVID test. In fact, these two bits of information are actually right at the top of the nursing assessment on the COVID unit that I currently work at. Right, so this is a very important part of getting a history and physical exam on the patient, because we want to find out where in the disease course is this patient. Are we in that first week where the viral phase is occurring, or the second or third week where we're looking at the early inflammatory phase, or the later phases where you're getting the microvascular changes and the blood clot risks and so on? All right, we're going to want to frequently monitor their patient's pulse oximetry. Ideally, we'll want their SpO2 to be 90% or above, and we want to know how much supplemental oxygen or support is that patient on. How much do they need to keep their SpO2 at or around 90%? 88 to 90% is a reasonable range to look at in these particular patients. We want to know if the patient is morbidly obese. Do they have a BMI above 30, right? We want to track the neutrophil to lymphocyte ratio generally over time. So we're going to be drawing labs maybe on a daily basis or more frequently depending on the severity of the patient's signs and symptoms. We're going to want to look at their ferritin to procalcitonin ratio. This is important because this can identify the possibility of a bacterial infection, a secondary bacterial infection that can occur generally within the second or third week following the onset of signs and symptoms of COVID-19. Um, Again, most patients with COVID-19 will not have a secondary bacterial infection, but a small subset will. And this can help us identify those patients that truly are candidates for antimicrobial therapy. All right, moving right along. Let's talk about anticoagulation. So, along with steroids, anticoagulation is going to be a very important consideration for hospitalized patients in particular, and for a certain subset of non-hospitalized patients that are going to be at elevated risk for developing clots and pulmonary emboli or embolisms. All right, so first and foremost, in all patients, we want to assess their bleeding risk, right? Is this someone who's going to be at high risk for developing a bleed, right? This is some patient that has a history of hepatic failure, cirrhosis maybe, and they have portal hypertension, and they've had a substantial history of bleeding esophageal varices. Well, clearly that is going to be a patient where the standard anticoagulation considerations probably not going to apply, right? So we want to apply some common sense and some good clinical reasoning. But in general, if you have somebody who's hospitalized, in general, for your average adult, your typical therapy is going to be 40 milligrams of Lovenox given subcutaneously every day. Lovenox or enoxaparin, which is low molecular weight heparin, also called low molecular weight heparin. All right, this is the typical recommendation, 40 milligrams sub-Q day, and I do give a lot of this. I give a lot of Decadron and a lot of Lovenox. I also give a lot of insulin, but that's because many of my patients are diabetics that require both short-acting and basal or longer-acting insulin therapy, but that's just an aside. All right. We may need to modify the dosing. If the BMI is greater than 30, we may need to consider a more intermediate dose, such as 40 milligrams BID. So we would give 40 milligrams of Lovenox sub-Q in the morning, and at night typically is what we do on the unit where I work. If the patient is in renal failure, so their GFR/CCR is less than 30, we actually want to consider heparin as opposed to low molecular weight heparin or chopped up heparin. With low molecular weight heparin, you can get lots of metabolites that can be formed, and you're not able to eliminate those metabolites, and they can then accumulate, whereas heparin tends to be much better in a renally compromised patient. The typical dose for heparin is 5,000 units sub-Q every 8 to 12 hours. So you're looking at 2 to 3 times a day if you're going to be doing heparin with renal considerations, right? Now, we always want to look at the risk versus benefit of anticoagulation. And we know that approximately 30% of patients that develop severe COVID, that is to say they require hospitalization, will develop substantial clots. And I have had a few of my patients develop pulmonary emboli. I think 2 of them have actually died, and pulmonary embolism was at least part of the reason they died. So it's a fairly common thing. However, if we aggressively anticoagulate patients, if we use full dose anticoagulation, and 40 milligrams of Lovenox every day is not considered a full dose situation, right? You're looking at like 1 milligram per kilogram once or twice a day would be more of a full dose situation with Lovenox, right? So if we're aggressive with Lovenox, approximately 8% of these patients may develop bleeding complications, right? So you kind of want to gauge, well, what's the risk of clot development in this patient? What's the risk of substantial severe bleeding, right? And you need to do a risk-benefit analysis. All right, we're getting there. Okay, so what about all the various interleukin 6 inhibitors that are out there, right? Well, if we can inhibit interleukin 6 during the inflammatory phase, maybe we can help these patients. Well, there's currently no good evidence. There are several studies that have been done, some pro, some against. Uh, I can't really say one way or the other. There's not really a whole lot of good evidence to suggest IL-6 inhibitors as we have currently used them, are going to impact mortality, let alone morbidity. Okay, what about hypoxemia? This is a very common problem, right? Hypoxemia is common, and clots are common. Well, the goal in these patients is an SpO2 of around 88 to 90%. You start basic and then titrate up to more advanced therapies, right? So start with nasal cannula, and then advance to a non-rebreather or a Venturi mask or a simple face mask as needed, and then add in additional support, high-flow nasal cannula, and then non-invasive ventilation, CPAP, BiPAP, and then if they failed all of those more aggressive therapies, then invasive mechanical ventilation may be considered, and I'll talk about that in some more detail. Prone positioning is also going to be very important in hypoxemic patients, right? And typically, if we are doing that, you're looking at putting them in a prone position approximately 12 to 16 hours per day. And generally, what you recommend is in a non-intubated patient, at least, you want that patient moving themselves around, right? So every couple of hours, maybe have them change their body position. Okay, it's time to roll onto your belly. Okay, you've been there for a couple hours, so let's roll onto your right side or roll onto your left side, or now let's go on your back, right? Get these patients moving around if they can. If they're intubated, then obviously we will have to be the ones moving the patient. That is a very complex procedure. Rotabeds are very helpful if you have them. And obviously, you need lots of people, and you need someone managing IV lifelines and someone managing the endotracheal tube, and then somebody coordinating the movement as a whole. Antiviral therapies. Well, we can consider antiviral therapies with very specific criteria. Okay, these patients need to have good renal function, and they need to have good liver function tests. The major antiviral therapy is remdesivir, and if you're going to give it, generally you're going to give it early during the viral phase when you actually have viral replication. So remdesivir, it tends not to be given after that first week because that's not really viral replication that's the problem. It's the immune system that seems to be the problem following the first week or so. All right. So there are some patients that may be good candidates for remdesivir. They need to be early in their within that first week. They need to have good renal function and reasonably good liver function tests to be a candidate for antiviral therapy. I will say that the role of or the routine use of remdesivir has really tapered off, and in fact, I've only seen a couple of my patients receive remdesivir. Okay, what are some other kinds of considerations? What about vitamin and pro-vitamin supplementation, like vitamin D? Well, if patients are deficient, I think it's reasonable to supplement them with vitamins, right? If their vitamin D levels are deficient or other vitamin levels are deficient. The evidence currently is fairly mixed. There are some studies for and some studies that don't show any benefit to various vitamin supplementation. So with the absence of robust evidence, I can't really make any strong recommendation other than to say it's probably reasonable to supplement them with a vitamin if they are deficient. Okay, moving right along. So let's talk about patients within that week 2 or 3 if they deteriorate, right? So we've had them in the hospital. They're continuing to deteriorate. They're in that second or third week, so they're moving through the inflammatory phase. So some considerations. This is where we want to start looking for secondary bacterial infections, right? Maybe it's bacterial pneumonia that's causing the deterioration. Consider a pulmonary embolism as well. PEs can cause particularly a very rapid changes in SpO2 and PaO2 for getting ABG, arterial blood gases, on these patients. A big pulmonary embolism can certainly do that. All right, so think about those and treating those appropriately. What about disposition or discharging these patients? So they get over the COVID, their PCR is negative, their signs and symptoms are improving or resolving. What are some things about going home? Well, we might want to consider DOACs, the direct acting anticoagulants, Xarelto, Eliquis, things like that. That is definitely consideration. Another thing I want to talk about is the so-called long COVID, or the quote-unquote long haul syndrome that some patients can develop. And this is where patients continue to have signs and symptoms uh, over 4 weeks. So they got COVID. It is now a month later. Their PCR is negative typically, and they're still having signs and symptoms. Then this is generally diagnostic for long COVID, or quote unquote long haul syndrome. On the average, we're looking at approximately 13% of patients will develop some lingering signs and symptoms after the 4 week time period. And in many of these patients, even 6 months after they have quote unquote recovered, they report having cognitive dysfunction and problems with malaise and fatigue, depression uh, going along with the cognitive function. Depression is a very common finding as well. And unfortunately, we just don't have a whole lot of evidence on treating long haul syndrome. There aren't any great therapeutics right now. We're still trying to figure that out, but just to let you know that it is a thing, it is documented and is well known at this point. And so some patients can receive great benefit from just being told that, hey, we know this is something that happens. We know that you're not faking it. This is not something you're making up. This is something that legitimately happens in some patients, right? And just reassuring people that, hey, we know that this is happening, and we believe you. We understand that you're having problems. Just acknowledging that and validating the patient's concerns in itself can be very helpful. Unfortunately, we don't have any specific treatments at this time. And then to conclude the overview of contemporary COVID management, I want to talk a little bit about ventilator management. All right, so the patient has failed, and again, ventilator management, intubating somebody, this is a last resort situation. We should never consider intubating patients early, like we were initially doing, and that led to lots of undue morbidity and mortality before we figured out that intubating and putting people on ventilators is actually pretty harmful, right? So we should try to exhaust all of the other less invasive options: nasal cannula, Venturi mask, high flow nasal cannula, non-invasive ventilation like CPAP and BiPAP, right? We should try and consider all of that before we put somebody on mechanical ventilation. So what are some general recommendations? Well, we know that low tidal volumes per ARDS-NET guidelines are generally recommended. So you're going to shoot for a tidal volume of about 4 to 8 milliliters per kilogram of ideal body weight. Most people are going to settle in around 6 or so. In addition to low tidal volumes, we want to look at a high PEEP strategy. All right, and typical starting point is going to be about 10 to 15 centimeters of water. It is not recommended that we do a ladder. We do not do a PEEP trial like we all learned in respiratory school, where you look at the patient's heart rate and blood pressure and their SpO2/PaO2, and then you titrate the PEEP up, right? And you titrate it up and you watch their SATs increase, and then you're looking at their heart rate and blood pressure to decrease, and you're kind of doing this over, several minutes to hours. Generally, if we're going to start somebody on a ventilator, start them at 10 to 15 centimeters of PEEP. Start them fairly high because they're going to need that PEEP, keep the alveoli open to increase surface area for oxygenation, splint the alveoli, and so on and so forth. Okay, we're going to want to titrate the FiO2, shooting for a PaO2 of about 55 to 80 millimeters of mercury. And of course, SpO2, we ideally like to keep it at around 90. And of course, we want to keep the P-plat, the plateau pressures, at 30 centimeters of water or under. Again, this is just general with the low tidal volume and the control of the plateau pressure. That's just general lung protective strategy considerations there. So essentially what you're going to do is you're going to do a lung protective ventilatory strategy and add a high PEEP support strategy to that. And that's a good starting point. Prone these patients approximately 12 to 16 hours per day. If this doesn't work, what are some salvage considerations? High PEEP recruitment maneuvers, right? Maybe increasing to 20 or even more. There are some people that are actually using more exotic modes of ventilation, such as APRV, airway pressure release ventilation, which by definition is a high PEEP strategy, right? Maybe consider something like that. You want to do high PEEP recruitment, right? You may even consider neuromuscular blockers, right? So giving them a dose of neuromuscular blockers if you have substantial patient ventilator dyssynchrony. Now, again, make sure that the ventilator settings are appropriate, right? The flow is appropriate for the patient, for example. But you may need to give a dose of neuromuscular blockers just to get that patient's oxygenation status under control. It's reasonable to consider a trial of inhaled pulmonary vasodilators, so things like nitric oxide, for example. And then as a last resort, if you have the capability, considering extracorporeal membrane oxygenation or ECMO. Obviously, not everybody has this, and the amount of ECMO nationwide is fairly limited. Okay, that concludes my basic overview of the most contemporary guidelines for managing the COVID patient, all the way from at-home care to the severe patient that may require mechanical ventilation. I hope you all found this helpful, and as major changes occur, I will try to update this, but it's been several months since I've done a treatment update, and I wanted to get one out as we go into the new year, and hopefully people find this helpful. Thank you all, and as always, please take care and be safe.